Hi, my name is Jacob Joseph, and I'll be discussing the evaluation and assessment of acute traumatic instability in the adult spine by Jacob Joseph and David Okonkwo from the University of Pittsburgh. The objectives of this presentation are to understand the indications of spinal imaging in acute adult trauma, as well as to develop an algorithm for the assessment of spinal instability. The key problem that needs to be solved is that all occurrences of traumatic spinal instability need to be identified while simultaneously minimizing unnecessary radiography, unnecessary bracing or precautions, all while minimizing any neurologic injury. There have been two major sets of clinical decision rules which have been published. Both of these were for the cervical spine and not for the thoracolumbar spine. To date, there have been no well-validated rules for the thoracolumbar spine. In the cervical spine, the first published decision rules were for the National Emergency X Radiography Utilization Study, which was based on 5 low-risk factors. More recently, in 2001, the Canadian C-spine rules were published, which were more complex and based on 3 high-risk factors, 5 low-risk factors, as well as an active assessment of range of motion. This graphic here shows all the indications for cervical spine imaging in acute trauma. On the left is the Canadian C-spine rules, and on the right is the nexus criteria. Starting on the right side with the nexus criteria, what we see are 5 low-risk criteria which are used to distinguish between patients who need radiography versus patients that don't. There are 5 criteria that are looked at. 1 is posterior midline cervical spine tenderness, 2 evidence of intoxication, 3 normal level of alertness, 4 focal neurologic deficit, and 5 painful distracting injuries. If any single one of these criteria are positive, then the patient requires radiography. If none of the 5 are positive, then no radiography is indicated. On the left side is the Canadian C-spine rules, which is slightly more complicated than Nexus. This flowchart starts with looking for 3 high-risk factors, the first of which is advanced age, or an age greater than 65, the second of which is a dangerous mechanism, which, as depicted below, shows that dangerous mechanism was considered to be a fall from an elevation of greater than 3 feet or 5 stairs, an axial loading force to the head and spine, an MVC at high speed, or a collision involving a bicycle or a motorized recreational vehicle such as an ATV. If any of those 3 factors are positive, then the patient does require radiography. However, if none of the 3 are positive, then the clinician moves on to looking for low-risk factors. If any of these 5 low-risk factors are positive, then the clinician moves on to an active range of motion test. These 5 low-risk criteria involve either a simple rear-end motor vehicle collision, sitting position in the ED, any evidence of ambulation from the time of the accident, a delayed rather than immediate onset of neck pain, and the absence of midline cervical spine tenderness. If any of those 5 are positive, then the clinician can perform an active range of motion test. However, if those 5 are not met, then the patient does require radiography. If the clinician is doing the active range of motion tests and they're able to perform it properly, then no radiography is indicated. However, if they're unable to perform it or the patient develops pain or other issues with the test, then radiography is indicated. These 2 criteria, the Canadian C-spine rules versus the Nexus, have been evaluated, and the Canadian C-spine rules were found to be more sensitive and more specific for cervical spine injury. It also resulted in lower radiography rates and missed less patients with significant injury than the Nexus criteria did. Thus, it is more common for most ERs to use Canadian T-spine rules at this point. As mentioned previously, there are no well-validated rules for the thoracolumbar spine. Therefore, we have developed an algorithm which is used at our institution for evaluation and assessment of all traumatic instability in the whole spine. Firstly, we have the criteria for spinal imaging. These are similar to the Nexus and Canadian T-spine rule criteria. If any patient is greater than age 65, has immediate neck or back pain, has a neurologic deficit, has distracting injuries, altered mental status with a GCS less than 15, intoxication, or has a high energy mechanism of injury, if any of those are positive, then they do meet criteria for imaging of the total spine. However, if none of these criteria are met, then the patient may be cleared clinically and the cervical collar may be removed. Please note that there is a separate presentation on the cervical spine specifically. If any of these criteria are positive, then neuroimaging is indicated with a CT that has at least 1 to 3 millimeter slice thicknesses. These slice thicknesses allow for appropriate sagittal and coronal reconstructions. In the thoracolumbar spine, a CT chest, abdomen, pelvis may be utilized with reconstructions and reformatting to provide appropriate imaging. If an injury is detected, then the rest of the algorithm is quite straightforward. An MRI may be considered if there's any concern for a discal ligamentous injury, an epidural hematoma, or as with the TLIC or the SLIC scores, the integrity of the posterior ligamentous complex is unclear. However, if no injuries detected, then the algorithm splits into 3. If the patient is awake and neurologically intact, then the next criteria is pain in either the cervical or thoracolumbar regions. In the cervical region, if there is pain, then the collar should be continued, and a delayed cervical clearance can be performed with either MRI to look for ligamentous injury or flexion extension X-rays, which can show some dynamic instability. Similarly, in the thoracic and lumbar regions, if there is pain, then symptom management is indicated. This can include bracing or potentially a surgical intervention. And also delayed imaging can be performed here with MRI or flexion extension films if indicated. However, if the patient is awake with a neurologic deficit, then an MRI is almost certainly indicated of the corresponding region of the neurologic deficit. If the patient is unexaminable or obtunded, but is clearly moving all extremities, then the patient can be cleared clinically. Next, looking at imaging modalities, these are quite straightforward. To start, X-rays or plain radiographs are no longer indicated in acute spinal trauma. They are neither sensitive nor specific for injury. Computed tomography is the acute imaging modality of choice. It is both highly sensitive and specific, and importantly, there is a high negative predictive value for a normal CT. This means that a negative CT is sufficient for clearance of a cervical spine. Magnetic resonance imaging is highly sensitive for injury, but of questionable specificity. And this involves primarily ligamentous injury, which is of unclear clinical utility. However, MRI is a modality for identifying epidural hematoma or traumatic disc herniations. In conclusion, a systematic approach to the evaluation of traumatic spinal instability is needed. CT is the preferred imaging modality for both the cervical and thoracolumbar spine. However, reformatting the thoracolumbar spine from a CT, chest, abdomen, pelvis is appropriate. MRI or flexion extension radiography can be utilized as a secondary imaging modality in certain cases. Thank you.